Okay, so we were talking about 4 T's of the PPH. What are these 4 T's? Tone, tissue, trauma, and thrombin. Okay, first of all, the most common cause is tone. Tone is the most common cause of the PPH. Anything that causes distension of the uterus can lead into PPH, is a risk factor for PPH. For example, multiple pregnancy, it decreases the tone, causes the over distension of the uterus and decreases the tone. So the uterus cannot contract back to its normal shape and size. Okay, multiple pregnancy, prolonged second and third stage of the labor, macrosomic baby, any history of previous PPH. Okay, general anesthesia is also cause of the PPH by decreasing the tone of the uterus. Okay, if polyhydramnios is there, okay, it also causes the over distension of the uterus. If there is chorioamnitis, any infection of the chorion or amniotic fluid, then if anything is distorting the cavity, for example fibroid, it also decreases the tone and causes the PPH. If the bladder of the patient is distended, bladder distension is also a factor. And then iatrogenic, for example, if patient is taking anything that, for example, calcium channel blocker or anything that contains magnesium, the risk of the PPH is increased in that case as well. Now come to tissue. Retain placenta. Okay, a tissue, whenever there is a tissue inside the uterus cannot contract properly and it causes the PPH. Retained placenta, and either if you call it morbidity adhere placenta or placenta accreta spectrum, anything. Okay, these also causes the PPH. Trauma, cervical tear or laceration, uterine inversion, uterine rupture. Okay, any trauma to the genital tract during the delivery process can result into PPH. Now final, thrombin. First of all, iatrogenic, if the patient is taking anything, for example low molecular weight heparin or aspirin, which can cause the bleeding tendencies. Okay, other than that, if the patient is experiencing hemophilia or for example in the case of preeclampsia or eclampsia or HELLP syndrome, the coagulation profile is deranged. Okay, in preeclampsia or eclampsia or in HELLP syndrome, this also leads to PPH. ITP or GTP can also cause PPH. if the baby is IUD, intrauterine demise हुआ है बेबी का, it can also lead to PPH. Abruption and amniotic fluid embolism, these two conditions are predisposing for coagulation profile derangement. Okay, so these two also causes the PPH. Now, if we know about all these risk factors of the tone, tissue, trauma, and thrombin, we can predict that the PPH gonna happen and what measures we can take to prevent this PPH. Okay, so if a patient, one more important thing, if a patient is having anemia, okay, in case of anemia, when a patient is diagnosed as a case of anemia at booking or 28 weeks, okay, we know that at first trimester and second trimester and third trimester we have different reference stages of the anemia. If at the booking the HB level should be 11 gram per deciliter, for example in the first trimester, and the second trimester it should not be less than 10.5 gram per deciliter. Okay, so when a patient comes for her booking appointment or the appointment at 28 weeks and her HB level are below the reference ranges, we should be alerted that this patient is a patient of anemia, and we should correct her anemia before her delivery so the risk of PPH can be minimized. Okay, so if the level of HB is less than the reference ranges, then iron supplementation, okay, iron supplementation either in oral form, or if the patient cannot tolerate it, then in the parenteral form can be given to prevent the risk of the PPH. Now, what pharmacological measures we can take intrapartumly? Okay, during the time of delivery, what we can do to reduce the risk of the PPH?